Staphylococcus, Micrococcus, and similar organisms. These are your objectives for this lecture. All right, so here's an introduction to Staphylococcus. So first, Staphylococcus can be normal flora. It can also be a pathogen or it could be nosocomial, so really it's a toss-up. Those that are considered pathogens include Staphylococcus aureus. This organism is catalase positive and coagulase positive. And then we have coagulase negative staph, or CNS. So Staph saprophyticus and Staph epidermis. Some other gram-positive cocci related to Staphylococci are Micrococcus. So these are generally considered normal flora. They are typically non-pathogenic but can occasionally be opportunistic. And then we have Rothia, which is formerly known as Stomatococcus. They are part of the normal oral flora and can be opportunistic pathogens in immunocompromised patients. Staphylococcus or staph can inhibit skin and mucous membranes. They can also colonize the skin, and they can also be opportunistic. Rothia, again formerly known as Stomatococcus, is an inhabitant of the human oral cavity. Organisms are either truly pathogenic or they can be opportunistic. So opportunistic organisms usually are those that will infect the immunocompromised patients. Staphylococcus aureus. So these have a cell wall that consists of the teichoic acid, and that helps for adherence to the mucous membranes, and protein A, which helps to interfere with phagocytosis. They also have some enzymes, so it's able to produce catalase, which increases cellular survival, and also produces coagulase, which inhibits movement of the phagocytic cells. And some organisms also produce beta-lactamase, which then results in organisms that are resistant to beta-lactam antibiotics, such as penicillin. Staph aureus is considered pathogenic, so it could be skin infections such as impetigo and abscess or cellulitis, which is shown in the picture on the slide. It could be endocarditis, could cause pneumonia, could also be as severe as toxic shock syndrome, scalded skin syndrome, or could be transmitted through food. So that results in food poisoning. For Staph aureus on a gram stain, we're going to see a gram-positive cocci, usually seen in clusters, or sometimes you may hear it be called a grape-like cluster. So if you look at the picture on the top left, you can kind of see it looks like a bunch of grapes that you would pick from a grocery store or from the vine if you have them. We can separate the staphs from the streps on a gram stain based on the arrangement. So staph is also catalase positive, which also can separate it from strep, and Staph aureus is coagulase positive. So generally we can do a quick ID for Staph aureus based on latex and agglutination that actually binds the coagulase or the protein A. Staph will also ferment mannitol, so Staph aureus will be yellow on a mannitol salt plate, and you can also use mannitol salt to screen for methicillin-resistant Staph aureus, or MRSA. So any Staph aureus needs to be screened for methicillin resistance, and if it's positive, it needs to be reported as such. Most Staph aureus are resistant to penicillin, therefore clinicians will often use oxacillin or methicillin to treat. Again, some methicillin resistance is there, so that's where we would then get MRSA, which is an acronym. Like I mentioned earlier, it stands for methicillin-resistant Staph aureus. The organisms alter their binding site so that the penicillin cannot bind to the cell wall. And since it can't bind to the cell wall, the penicillin can inhibit the cell wall synthesis. When organisms are methicillin resistant, they carry a gene known as MECA gene. When we do susceptibility testing for Staph aureus, we'll test using the 24-hour diffusion, which will detect oxacillin resistance. If it is oxacillin resistant, then you will report all cephalosporins as resistant as well. And we will also perform a beta-lactamase testing on all isolates. Staph epidermis. This is the most frequently recovered coagulase-negative Staphylococcus. Typically, it's a result of a nosocomial infection, often due to an indwelling catheter, such as some types of intravascular device that could be recovered in an immunocompromised patient. Staph epidermidis is normal flora of the skin and mucous membranes. But once again, if given an opportunity, Staphylococcus epidermidis will be the pathogen for an opportunistic infection. So once again, it will happen in indwelling devices. This can be a contaminant of a wound culture, and we can also recover Staph epi in improperly collected blood cultures. So if you think back to the specimen collection lecture that we had, it's very important that a wound specimen and blood cultures are being properly collected. So we try to minimize, the normal flora that is just there. Staph epi is also oftentimes a pathogen, and those can cause because of nosocomial urinary tract infections, as well as infections of prosthetic heart valves. Staph epi. We will separate from Staph aureus based on the result of the coagulase test, which it would be negative. So Staph epi is also gram-positive cocci, which is seen in clusters and pairs, and it is catalase positive because it's a staph. It's coagulase negative, and so that separates the non-coagulase staphs, which is epidermis, from Staph aureus. It's a medium to small size colony. It is non-hemolytic, and it is novobiocin sensitive, so we're going to use a novobiocin disc for identification, not for susceptibility testing. So the novobiocin will differentiate Staph epidermidis from Staphylococcus saprophyticus. So we do have unpredictable patterns as far as antimicrobial susceptibility testing. So therefore, you need to do susceptibility testing on any staph that is recovered. Sometimes the nosocomial strains will be highly resistant to a lot of antimicrobial agents, as well as beta-lactamase positive. Staphylococcus saprophyticus. This organism inhibits the genital urinary tract. It's most frequently recovered coagulation negative staphs from urine in non-hospitalized patients. It is a catalase positive because it's a staph. It is coagulase negative because it's not Staph aureus, and it is resistant to novobiocin. So an easy way to remember the novobiocin with epidermidis and saprophyticus is that the S's do not go together. So Staph epidermidis is susceptible to novobiocin, whereas saprophyticus is resistant. So saprophyticus S is resistant R. We'll usually use susceptibility testing to most antimicrobials except for the nalidixic acid. Micrococcus. It is not recovered quite as frequently as the staphs, however, we do need to mention it. It is a catalase positive, coagulase negative. The pigment on the growth of the agar plate is a lot of times what helps separate Micrococcus from the Staphylococcus. So it can be a beige, bright yellow, or orange. So if you look at the picture on the slide, you can kind of see that it's got kind of a yellowy tone to it, where your other Staphylococcus would kind of be like a white color. The colonies are larger than staph. It is still a gram-positive cocci, but is usually formed tetrads versus clusters. And unless this is determined to be clinically significant, there's no reason to do susceptibility testing.